So today I'm going to give a presentation of a case which came to our hospital in previous month, and this case was disseminated herpes zooster. So this was the present introduction of the patient. Patient name was Asif, and she was a wife of Asif. She admitted to our hospital on the 3rd of March 2025, and we admitted her in isolation ICU. She was 25 years old. So her presenting complaint was that 25-year-old female, known case of pregnancy-induced hypertension, gravida 1 para 1 plus 0. She came to us with complaint of generalized vesicular eruption for last 5 days, and she was also having a complaint of fever for last 4 days along with shortness of breath. And shortness of breath was the prime reason of admission to our hospital. So this was the history of presenting complaint. According to her father, as she was not able to give adequate history, so we took all the history from her father, and he told us that she was alright when she recently discharged from Civil Hospital Karachi on 23rd of February 2025. Actually, on 30th of February 2025, she admitted in Civil Hospital Karachi for a C-section, and she referred to a primary hospital from where she was a booked pregnancy, and the reason for the referral was that she was having a really high blood pressure, and they could not able to manage that emergency, and they referred her to the Civil Hospital Karachi, where her emergency C-section done because of imminent pregnancy. And after the C-section, she got hospital-acquired pneumonia, and she remained for 3 days in medical ICU, and after that she shifted to the ward, and that was the main reason for her prolonged hospital stay. And she got discharged on 23rd of February 2025. And after her discharge, she was alright, and then 5 days before coming to our hospital, she all of a sudden developed a localized vesicular rash on the back, and next day that rash traveled in front of her chest, and on the next day she started to have fever which was really high grade, but they were not able to document that fever, monitor that fever. And then along with the fever, she started to develop a very severe shortness of breath, which was gradual in onset, and with the passage of time that was getting worse, and even she was having shortness of breath at rest, which was her prime reason who came to our hospital. So her past medical and surgical history. So she had a pregnancy-induced hypertension, and for that she underwent an emergency cesarean section on 30th of February 2025 because of imminent eclampsia. Then she subsequently developed hospital-acquired pneumonia, and that makes her landed in medical ICU. And she also got one PAC cell transfusion during her after her C-section. Her social history and family history. Family history was not, we were not able to get because she was an adopted child, and her social history was she was not taking any recreational drugs, and was not having a history of smoking or any habit of illegal drinking, when she was up and about and was very much able to do her daily tasks of the day. So her obstetrical and gynecological history. Basically, she was a booked pregnancy at some local hospital at Bardia town in Karachi, and according to her mother, she was having a normal antenatal checkups, but only in one checkup she got a really high blood pressure, for which they just answered that there is no issue in it, and it is normal during a pregnancy. That's what they were counseled about. And she was gravida 1 para 1 plus 0, and during her C-section, she delivered a baby girl at 38 weeks of age. and she was also having a really high respiratory rate of 20 breaths per minute. And her RDS was 180 millimeter. We sent some lab investigations from here, and we sent CBC, UC, LFTs, blood culture, serum lactate, uric acid, urine albumin, ABGs, and we also got her chest X-ray. And later on, we found out that she was having bilateral infiltrates in her both lung fields. So we did a clinical examination in ER, and on examination, we found that she was very restless, anxious, and confused, but she was oriented with person, place, and time. Her cardiovascular examination was within normal limits, but on auscultation of her chest, we found mild crepitation on her both lower zones of lungs, and she was having a GCS of 13 by 15, and her abdominal examination was also abnormal. So we did a dermatological examination with a hand lens, and we found that there were fluid film lesions less than 1 centimeter in size, and they were closely growth space, and they were disseminated to the whole body, including her face. So this was her presentation when she came to our ER, and you can easily appreciate that there is both drop of vesicles, and they are very closely spaced, and you can easily appreciate that these lesions are on her face, on her legs, and on her back of the hands and forearms. So we did specialist consults, and we also gave her treatment in the ER, and we gave her injection Melvin 1 gram IV staff, injection Metromycin 1 gram IV staff, and she also got injection acyclovir, and we also gave her injection hydrocortisone 250 mg IV staff as she was clean, and she was having a normal postpartum bleeding. But they also made us point out that patient must be evaluated for deep venous thrombosis and blood thrombosis. And the dermatology people, they evaluated the patient, and they diagnosed this patient as disseminated herpes zooster. And they advised the treatment, which was injection acyclovir 500 mg IVDDS for 5 days, and combination of beta-methasone with gentamicin mixed with liquid paraffin for topical application twice a day for 14 weeks. And also they advised amitriptyline 25 mg once daily at bedtime, and injection ceftriaxone 2 gram IVOD for 5 days. So after getting initial treatment in ER, patient transferred to intensive care unit isolation area, and she transferred at 12:35 p.m. And upon her arrival, her vital signs were she was having a blood pressure of 126 by 80, her heart rate was 128 beats per minute, and her oxygen saturation was 98% with 50 liters of oxygen. But she got a really bad breathing, and her respiratory rate increased from 20 up to 22 breaths per minute. So we also evaluated her evaluated her GCS, and her GCS was 10 by 15. So we found that she also got a drop in her Glasgow Coma scale, and at that moment we counseled her father for possible elective intubation and ventilation. Her father gave us consent, and we performed elective intubation and ventilation with 7.5 French ED tube So we put patient on mechanical ventilation with the setting of control board, and her respiratory rate was 16, and cardiac volume we said was 450, and her T was 5, and her FIP was 100%. So this was her treatment chart upon her arrival on first day in medical ICU, and we started her on meropenem, flagyl, acyclovir. So these were her antibiotics, and on her first day we found her labs. She was having a normal TLC count of 6.9. Her HB was 13.1, and but her D dimers they were very much raised, and more than 10,000 we got those values. Her ESR was 45. And she was having a really normal urine output in 24 hours. Okay, so we also noticed that after 9 hours of admission in medical ICU, she responded really well to the treatment, because for 9 hours she was having a constant rise in her temperature, and after 9 hours you can easily appreciate that she dropped her. There is a dip in her temperature over here at the 9th hour of her admission in medical ICU. So on the second day of her admission in medical ICU, we got a consult of infectious diseases expert from SIUD, and we got a telephonic consultation, as we don't have any infectious diseases consultant in this hospital. So we just discussed the whole scenario. We shared the pictures and the current clinical status of this patient. So the expert, he advised us to add injection vancomycin 1 gram IV OD, and he also made a really big concern that he hasn't seen such good prognosis of these patients. So these were the pictures of second day in medical ICU.
मुझे बताओ कि डे 1 पे जो तुमने मैंको और वीडियो स्टार्ट कर, हम लोगों ने सेप्टेम्बर में लिखी थी,
जी जी
ठीक है, इन्होंने ER से इनको दी मैंको और भी, ठीक है, फिर आप कहते हैं कि बाद में आगे ने सेप्टेम्बर स्टार्ट कर दी, ठीक है, फिर अब आप कह रहे हैं कि सूट वालों ने कहा कि नहीं मैंको तो स्टार्ट कर, तो हमने मैंको स्टार्ट कर दी, तो बस तक कन्फ्यूजन।
अच्छा सर, इसमें ये है कि जैसे फर्स्ट डे पेशेंट हमारे पास मेडिकल ICU में आया था, तो हमने इंजेक्शन मारा था ना फ्लैजेल और
नहीं, हमने ऑर्डर सेप्टेम्बर दिया है,
आपने एडवाइस
ठीक है,
बट इमरजेंसी से ही जो है वो इंजेक्शन हमको मेरापेनेम जो है वो पेशेंट को जो है ना वो स्टार्ट हो गया, और देन फिर आगे से जो मेडिसिन टीम थी उसने भी फिर यही एडवाइस किया।
Why is it like the first treatment of choice meropenem?
इस तरह रेजिस्टेंट डेवलप की उम्र पर हक भी चॉइस की लेगी
In Pakistan,
एंटीबायोटिक।
it's not advisable because we already have so much resistance.
जब स्किन इन्फेक्शन में देखिए सेप्ट्राक्सोन इज ऑलवेज द बेस्ट ट्रीटमेंट, व्हाट वी हैव बीन observing over the years, the results are very good, और हम हर पेशेंट को ये एडवाइस करते हैं द मेडिसिन आर ऑलरेडी चेंज, मैं कोई भी
I think मुझे लगता है कि the reason for changing it on अभी इंटीग्रेशन का बता दिया।
हाँ, इंटीग्रेशन
So probably the thing that was in the mind वो ये था कि DIC and complications. Basically, I think these were the things that was. But I totally agree कि vancomycin should be the choice because आप skin के infections को cover कर रहे हैं. That's right. जगह से neopenem start करने की वजह ये।
Actually, हमारे पास जो पिछली दफे काफी सारे जो स्किन रिलेटेड इन्फेक्शन आते हैं, तो जैसे एविएशन इन्फेक्शन से तो वो यूजुअली दे start off with meropenem and vancomycin. So what happens is that they do not respond. फिर जब हम उनको IV रोसिपन देते हैं तो suddenly they, I mean in 2 days the whole ulcer or whatever starts healing.
बिल्कुल सही कहिए, लेकिन ये चीज़ आजकल हम लोग बहुत ज़्यादा कॉमन में बहुत ग्रेव अंदाज में काउंसिल किया था, बिकॉज मुझे नहीं लगता था इवन कि 24 आवर्स सर्वाइव भी कर पाएंगे।
ये तो पहले दूसरी
लेकिन आपकी बात दुरुस्त है कि आई टोटली एग्री कि कुछ एंटीबायोटिक्स हम अनड्यू यूज ना करें, बिकॉज और आगे फ्यूचर में, और इवन अगर करते हैं, जैसे फॉर एग्जाम्पल कोई बहुत सिक पेशेंट है आईसीयू में और आपको लगता है कि पेंडिंग सेप्सिस में आप उसको अपग्रेड एंटीबायोटिक उसको जल्द अज जल्द डाउनग्रेड भी करते हैं। जैसे पेशेंट क्रिटिकल स्टेट से बाहर आ जाए और आपके पास कल्चर्स की रिपोर्ट आ जाए, तो आई थिंक इट शुड डीएस्केलेट एंटीबायोटिक, बिकॉज ये चीज़ बहुत जल्दी हम देखेंगे कि हम बहुत सारे एंटीबायोटिक्स के हवाले से, खासतौर पर कोविड के बाद, मीलोपेनिल इज नॉट वेरी फ्रीक्वेंट, आई बी वेरी।
So this was her second day in medical ICU, and you can easily appreciate that there is a whole body involvement of these vesicular rash. So this was her treatment on second day in medical ICU, and we started injection with vancomycin on the advice of infectious diseases expert on second day in medical ICU, along with meropenem, flagyl, and acyclovir. So on the third day, we also having a concern that she's having a disseminated infection with herpes zooster, and we need to assess her GCS. So in order to assess her GCS, we just stopped her sedative medications, and we then evaluated her GCS, and we found out that she was responding, she was obeying commands on stopping her sedations, and she was having a GCS of 10/15 on ETT. So we took a TB trial, and her TB trial was a big success, and we extubated that patient and took her on BiPAP with ST mode. And on the third day, we also noticed that there was a significant improvement in her lesions, especially on her forearms.
Within 24 hours ही मिल रहे थे, मतलब ड्रास्टिक चेंज लाने के हम उम्मीद सोच चुके थे कि इस तरह से आए तो
पहले दिन से ऐसे हालात थे कि
बिल्कुल बिल्कुल।
And on third day, we noticed that there was a drop in her hemoglobin levels, and which were 7.9. And on that, we transfused one pack cell of blood. And during whole her treatment process, we got a really severe concerns from her family regarding financial issues and affordability issues. And even we also stopped her labs like APLA and ANA profile, and even we could not able to send her blood cultures because of their severe financial and affordability issues. And they were trying really hard in order to find out a space in any public sector hospital, but they could not able to find. And her father was also a Hawaldar from Pak Army, and he also tried through his commanding officer to make a space in PNS Shipa, but they could not able to find her. So eventually somehow through same government, they found a space in Sindh Infectious Diseases Hospital in isolation ICU, and eventually that patient moved and got LAMA from our hospital and moved to Sindh Infectious Diseases Hospital, that is actually Pacho Karachi. So a few days back, I was in contact with her father, and few days back, he sent me this video, and you can easily appreciate that you can there is a crusting of lesion, and you can easily appreciate the normal skin. And so ये है कि you can easily appreciate the normal skin, and she was talking, and she was maintaining her oxygen saturation just on nasal prom, merely of 2-3 liters of oxygen. So at the end, we have some key points. So in postpartum, immunosuppression increases the susceptibility of infections such as herpes zoster. And disseminated herpes zoster in immunocompromised individuals requires early antiviral therapy. Respiratory distress in postpartum patient necessitates ruling out pulmonary embolism and
Actually,
sepsis.
we treated pulmonary embolism.
Yes, we started her on
along
campaign.
with the treatment of herpes.
She was on injection of surveillance of PD16. And timely administration of broad spectrum antibiotic and antivirals can significantly improve the outcomes of the patient. But here we had a really big problem that they were having a big time issue of finance and affordability and pay off our bills. So we really acknowledge the efforts of ER team, ICU, OBGYN team, and dermatology team.
एक वक्त ये भी था कि वेंटिलेटर पे इन्होंने कहा था कि पेशेंट या पेशेंट को एक्सट्यूबेट करना
They were like, we cannot afford
when withdraw.
We cannot afford, and you just stop all of her care and just remove her from ventilator care. Yes, they told us.
क्योंकि इसकी में मतलब जिस तरह था ना कि पेरेंट्स भी इसके adopted
Adopted child.
was very मतलब इसकी social situation भी बहुत grave थी और disease भी बहुत grave थी.
So this was all about regarding this patient. So do you have any question for me? You can ask. So I have worked for like 7 to 8 years in medical ICU, and I've never been encountered with such patient ever in my clinical experience. And this was first experience that I got such a grave disease and such disseminated presentation of herpes zoster. So it was also a kind of learning for me, and I suppose that this process, this learning process should be continued in a doctor's life, and this is very important for your growth in career and in your future to give adequate care towards your patient. So this is all about it.
I just want to say one thing, like I have one concern, not related with that case, but regarding the llama patients. Previously we have option of discharge on request, discharge and the llama. And nowadays we have only two heads, like llama and discharge. In such situation when we are transferring a patient from one facility to another facility because of non-affordability or finding space anywhere else where they can afford in less prices. So should we have, like, I have a question from the administration, should we have this option of discharge or request, because then the number of llama patients is going on increasing.
देखिए दैट इज़ क्लियर कट पॉलिसी कि अगर इफ़ देयर इज एनी लाइफ थ्रेटनिंग सिचुएशन तो उस सूरत में हमें लामा करना है पेशेंट लाइक दिस पेशेंट जैसे ये पेशेंट वॉज मैनेज वेल और एक्सटूबेट भी हो गया था सब चीज़ें क्रिटिकल फेज से तो निकल आया था एक पेशेंट तो हम ऐसे पेशेंट को DOR कर सकते हैं डिस्चार्ज में बिल्कुल
Because currently residents were saying that there is only two things, like llama and
No.
discharge.
इट्स नॉट लाइक दैट
Not like that, we can do that.
Actually, मैं इस बात को थोड़ा मैंने लगे ना हमारी मेडिसिन में बहुत आप इससे पीछे मेडिसिन एक कॉमन सिक पेशेंट होते हैं तो व्हाट वी डू इज इवन इफ यू आर अगर पॉलिसी का जैसे नामा की तरह ट्रीटमेंट आप थोड़ा बहुत चॉक आउट कर देते हैं मतलब इट्स वो होता है DOR ऑन द बुक आप नामा लिख देते हैं लेकिन होता है DOR तो DOR तो मतलब वेरी एथिकली रॉन्ग है एक पेशेंट को बगैर किसी उसके आप अगर अफोर्ड नहीं कर सकते ठीक है हॉस्पिटल एडमिनिस्ट्रेशन की पॉलिसी होती है उस पॉलिसी को भी हम रख लेते हैं कि ठीक है क्योंकि सिक पेशेंट है कल को ये कह सकता है कि हम जाना नहीं चाह रहे थे फिर क्योंकि बाद में फिर आफ्टर रिजल्ट हो मेक श्योर कर देते हैं कि उसको करें DOR ही का
जस्ट इन दीज केसेस मेरा ख्याल ये है कि एक आपको सिर्फ टू बी ऑन सेफ साइड एक अंडरटेकिंग ले लेनी चाहिए था अगर आप DOR भी कर रहे हैं ऐसे पेशेंट को तो एक अंडरटेकिंग ले लिया कुछ पेशेंट्स ऐसे भी जो यहाँ से हमारे ICU से गए हैं जो कि आइनोट्रॉप सपोर्ट पे होते हैं और इंट्यूबेटेड होते हैं या
उनके लिए तो स्पेशली आप
जी और उनको तो लामा ही करना है ऑब्वियसली
रस्ते में अगर कुछ हो गया तो फिर बहुत बड़ा इशू
तो मेरी जो कम्युनिकेशन पहले हुई है ICU के डॉक्टर्स के साथ या फील्ड ऐसे भी डॉक्टर्स के साथ रिगार्डिंग दिस के अगर ऐसा पेशेंट है जिसको लाइफ थ्रेटनिंग सिचुएशन में है तो ऐसे पेशेंट को आपने ऑब्वियसली लाना ही करना है।
देखिए पेशेंट आईसीयू का पेशेंट हमेशा लाइफ थ्रेटनिंग ही होता है। People who are getting admitted to ICUs are not regular people. They require oxygen, they require inotropic support, they require antibiotic. वो तो लाइफ थ्रेटनिंग ही है। How can you say कि ये पेशेंट जो है नहीं ये ठीक है? You cannot say that.
बट सर ये केस सॉरी टू इंटरप्ट सर ये जैसे केस था ना,
Sorry, I came late, so I don't know.
तो 3 दिन का स्टे है पेशेंट का और उसके बाद पेशेंट वाज एक्सटुबेटेड ऑफ inotropic सपोर्ट एंड ही वाज मेंटेनिंग सैचुरेशन विद लो ऑक्सीजन मेरे ख्याल से। अच्छा अच्छा तो ऐसे केस जी आई थिंक ऑफ उसके बाद ऑक्सीजन इसकी जो है ना मेरे ख्याल से कुछ रिक्वायरमेंट कम हुई है।
बाईपैप के ऊपर थी बट ये था कि मास के ऊपर फिर हमने हाई फ्लो ऑक्सीजन पे उसको मूव करवाया था जब ये दूसरे सेटअप
ओके
क्योंकि बाईपैप के साथ पेशेंट को फिर यूपीएस का मसला वो मशीन जाना वो फिर रिस्ट्रिक्शंस थी थोड़ी।
ही गॉट लामा ऑन द डे ऑफ एक्सटुबेशन।
हाँ बिल्कुल।
ओके
Morning we extubated the patient and they took her around 3:30 p.m.
दैट इज लामा। तो एक्सटुबेशन के बाद भी एटलीस्ट हमें 24 आवर्स तक पेशेंट को रखना है और ये देखना है कि इसकी वो रिकवरी और बेहतर हो रही है या ऑक्सीजन की रिक्वायरमेंट कम हो रही है तो देन हम डिसीजन ले सकते हैं DOR का विथ एन अंडरटेकिंग।
I think you are clear.
बिल्कुल।
ट्रीटमेंट के साथ
I think आप उससे लिखवा देना कि हम अपनी मर्जी से जा रहे हैं
बिल्कुल।
और एक स्टैम्प कर दीजिए उनका एक सिग्नेचर ले लीजिए तो मतलब
और जैसे लामा का जो सिलसिला होता है ना कि कभी-कभी ऐसा होता है कि बहुत से पेशेंट हमारे साथ हुआ है मेडिसिन में बहुत से पेशेंट आईसीयू से इसलिए डिस्चार्ज करवा के ले जाते हैं किसी और हॉस्पिटल में लेके जाएंगे बहुत से होते हैं और वो फिर घर ले जाते हैं एंड द पेशेंट एट टाइम्स डोंट गो टू अदर हॉस्पिटल पेशेंट की डेथ भी हो जाती है तो उस सूरत में फिर आपके पास एक वो होता है कि ये कल को आपको ये कह सकते हैं कि भाई इन्होंने मैं डिस्चार्ज कर दिया पेशेंट को खराब कर दिया। तो मेरा ख्याल है कि डॉक्यूमेंटेशन ज़रूरी है सिर्फ पेशेंट्स में और आप DOR के प्रोसेस के जरिए ही प्रोसेस करें ताकि ट्रीटमेंट और
And one thing I have a concern regarding GCS. मैंने भी ये पेशेंट ER में देखा था तो जो आपने लिखा है 10/10 और 15 GCS का।
That was on her extubation. On arrival she was having a GCS of 13/15.
13/15 yes
मेरे ख्याल से थर्ड डे भी या सेकंड उस दिन
ओके
के
मैंने इसमें 10/15 देखा तो
वो ड्रॉप हुआ पहले तो था।
I have seen this patient in ER. What was the GCS on arrival?
In ICU she was having a GCS of 10/15.
But what I remember that when I seen her in ER, it was around 13/15. She was a little bit disoriented. Spontaneous eye opening भी थी और verbal respond कर रही थी। जी जी बिल्कुल ER जी बिल्कुल मेरे सामने ही आप आए थे उस वक्त आपने देखा।
हाँ ये 13/15 ER।
राइट ठीक।
तो ये था कि जैसे जैसे पेशेंट टाइम गुजरता जा रहा था शी वाज kept dropping her GCS level.
Okay.
That was also make us consider to put her on